we're going to be talking about the myths and misconceptions around cognition and Parkinson's disease. And we're going to dissect some of these misconceptions around this. We're going to talk about cognitive impairment. What is that? Does it mean you're going to get dementia? What is the difference between the different dementias, Alzheimer's, Parkinson's disease dementia, Lewy body dementia? Are we all destined for dementia, or is this something that we can mitigate? Are there options even for treatment for Parkinson's dementia or other dementias? So lots to uncover and unpack today, and we're very excited. We have an expert in this area with us today is Dr. Joseph Quinn. He is a professor of neurology and the vice chair for research and the Parkinson's Center director at the Oregon Health and Science University in Portland, Oregon. And his research focuses on cognitive decline in Parkinson's disease and other neurodegenerative diseases, and has a bunch of interest in and work in biomarkers in Alzheimer's, improving modeling systems for screening potential treatments for Alzheimer's disease, treating new compound or testing new compounds that target Alzheimer's, works in Parkinson's disease, dementia, all of it. So this is someone that has a breadth of research knowledge as well as clinical knowledge. So we're very excited to have Dr. Quinn with us, and I know he has a lot to cover today. So Dr. Quinn, welcome. I am going to hand this over to you. And really quick, we have a ton of people today. We do want you to ask your questions in the chat. We will try to get to as many of these questions as we can.
Great. Well, Nissa, thank you for the nice introduction, and thank you for the invitation, and thank you for coming up with the idea for what the talk should be about and giving me some tips on what exactly I should cover. I'm trying to get my slides to behave themselves, and shoot. Okay. Is that displaying appropriately? That should be the first slide title. Okay, great. Well, thanks again. This is my favorite topic, really. So that is cognitive function and Parkinson's disease. So appreciate the opportunity to talk about it a little bit. Sorry, I have things floating around on my own screen. There we go. All right, so as I say, and this came up with this title of the talk, which I think was a great idea, and even gave me bullet points to try to cover. So I'm going to go through them here. So one myth is that all dementia is the same, and I'll clarify what the facts are there. There's also, every time I talk on this topic, regardless of what the audience is, there's some question about whether dementia and Alzheimer's disease the same thing, or are they different? I'll get to that in a moment. Another question that frequently comes up from both doctors and patients is dementia normal? Is it just a normal part of aging? And then in the case of people with Parkinson's disease, is it something that everyone is destined to get? We often think of dementia primarily about memory loss, and memory is what comes to people's mind, I think, first when we talk about dementia. But there are aspects of dementia that go beyond that, and I'll describe that. And then the last point, in some ways, is the most important point. Why are we talking about this? Well, it's because there are some treatment options available for people who are struggling, and we should exercise those treatment options. So I'm going to go through these myths one at a time. And try to shed a little light on them. Starting with this question of, well, are all dementias the same? And the first thing I should do is give a definition of dementia. And one simple definition of dementia is that it is an impairment in cognitive function and mental functioning, which is sufficient to interfere with the activities of daily living. So there are gradations of cognitive impairment that are below that level, that are just kind of a nuisance. And we don't use the term dementia until things are actually interfering with activities of daily living. And what do I mean by activities of daily living, or sometimes abbreviated LDLs? Well, taking medications, managing appointments, managing finances, and um, and driving safely. I apologize. My screen keeps moving your picture around, so I get stuck a little bit. But this is the definition of dementia. So dementia is really a broad term, and it's talking about a level of cognitive impairment that is severe enough to interfere with everyday function. But all dementias are not the same. And I like this figure because it illustrates the concept that dementia is kind of an umbrella term. And dementia refers to a variety of different conditions that give rise to cognitive impairment sufficient to interfere with activities of daily living. And a partial list of those dementias is shown below. I don't know if this pointer will work. So Alzheimer's disease is the most common form of dementia. Vascular dementia, which means dementia due to multiple strokes, is sometimes considered the second most common. Then there are Lewy body dementias, which I'll describe in a minute, and then frontotemporal dementias. And there's other dementias as well. But the point is, dementia is an umbrella term, and these particular types of dementia come under that umbrella. So people then, say, well, what's the difference between dementia and Alzheimer's disease? They tend to be used interchangeably. So Alzheimer's disease is a dementia. Not all dementias are Alzheimer's disease, but Alzheimer's disease is a dementia. It's a slowly progressive dementia. It starts with memory and starts to affect other mental functions over time. And I think most people are kind of familiar with this aspect of things. In contrast to Parkinson's disease and some of these other diseases, the ability to move and get around is typically not affected in Alzheimer's disease until very late stages. And when we say somebody has Alzheimer's disease, we are inferring that the tissue changes in the brain are things that we call plaques and tangles, plaques and tangles. So when we make a clinical diagnosis of Alzheimer's disease, we're saying that we think the underlying tissue changes are these plaques and tangles. And most people who are being evaluated for dementia have an MRI scan or a CAT scan. These plaques and tangles cannot be seen on MRI scans or CAT scans, but they can now, at least the plaques, can now be seen with a special scan, a special type of PET scan. And the plaques are composed of something called amyloid, AMYLOID. There on the final bullet point, amyloid. And this relatively new PET scan can identify amyloid plaques. So this is an advance since I first started practicing neurology. We used to not be able to tell whether in a living brain whether people had amyloid or not, and now we can, and that's allowed us to develop some treatments for this problem that I'll talk about later. Those treatments are actually targeting the amyloid, so they are treatments that actually get the plaques out of the brain, and they do that quite effectively. But there is more to the story. The clinical benefit is smaller than we would like, and there are some risks of those therapies, but we'll put that aside for now. So the myth that I'm on here is, is Alzheimer's disease the same as dementia? And the answer is no. Are all dementias the same? And the answer is no. Alzheimer's disease is one dementia. I mentioned these scans that are now available to see Alzheimer's disease. The two scans on the left are a person without amyloid plaques in the brain. The two scans on the right are people with amyloid plaques in the brain. So the dark red areas, that's where amyloid is. And you can see it's really black and white between the left scans and the right scans. And this is what allows us to tell people whether they have amyloid in their brain right now. And then we can think about whether we ought to try to do something about it. But there's other types of dementia, and the one that I think is of greatest interest to this group is something called Lewy body dementia. And in the case of Lewy body dementia, the cognitive problems and the movement problems come on together. The movement problems are very similar to garden variety Parkinson's disease. That is, there's slowness and there's stiffness and there's walking changes. Tremor is less common with Lewy body dementia than with Parkinson's disease in general, but sometimes it appears. And this entity of Lewy body dementia is also characterized by hallucinations, by seeing things that are not there. And this is while people are awake. This is not dreaming. This is things that they see while they're awake. And in the case of Lewy body dementia, it is not always provoked by medications. It's just spontaneous hallucinations. Um, it's also become clear over time that when these people have hallucinations, if they're given some of the medications that are available for hallucinations, they have bad side effects. So that's a characteristic of this condition. Some of the patients have very marked fluctuations in their alertness and in their ability to function. Everybody with neurologic disease fluctuates to some extent, but these fluctuations in Lewy body dementia can be quite profound. And then the other characteristic is that people sometimes act out their dreams. Our brain is set up so that when we are dreaming, we don't act out the dream, where our body is paralyzed when we're dreaming. Um, and in Lewy body dementia, also in Parkinson's disease, sometimes that mechanism goes awry and people really act out their dreams in dramatic fashion, and the bed partner is often beat up. Now, another really confusing issue is, well, what is the difference between Lewy body dementia and Parkinson's dementia? And what it really comes down to is the timing of the thinking problems and the movement problems. Okay, so in Lewy body dementia, as I just stated, the cognitive problems and the movement problems come on in close proximity to one another. They sometimes come on at the same time, but sometimes one is appreciated more than the other. But they come on close to one another. But that is distinguished from dementia that sometimes occurs in Parkinson's disease, which typically occurs many years after the diagnosis of Parkinson's disease. So people will come in with a tremor or stiffness or slowness, and they'll get treated for Parkinson's disease, and their movement will improve. But some of those patients years later develop very significant cognitive impairment and dementia, and that we refer to differently because it is a little bit different in terms of coping with it and understanding it. So that's called Parkinson's dementia. Now, another challenging issue comes up. You might just ask, as we get older, you can have multiple things happen to any part of your body. Can you have more than one type of dementia at the same time? Can you have more than one thing happening in the brain tissue? Can you have strokes plus Alzheimer's disease? Can you have Alzheimer's plus Lewy bodies? And the answer is yes, you can have more than one type of dementia at the same time. I'm not going to go into that right now, but when I get to the tail end of the treatment recommendations, that's going to become a little more relevant. All right, so we've gotten through our first two bullet points, our first two myths and preconceptions, and now we're on to the third bullet, which is that the myth is that dementia is a normal part of aging. And the facts are dementia, all forms of dementia increase with age. The older you get, the higher risk of dementia. And it is an unfortunate fact that when people are over the age of 85, or in the population, at least half the population has dementia over the age of 85. And you're never really in the clear. The risk continues to go up after the age of 85. But there still are some remarkable or a substantial number of people who are spared dementia. There are many studies of this around the country trying to understand how people live to these late ages and avoid any sort of dementia. And the secret is still a little bit unclear, but it's some combination of genetics and lifestyle that that really play a role in how things turn out for each individual. So um, the things that we all kind of know are good for our heart, in terms of healthy diet and exercise and taking care of blood pressure and all that kind of thing. It's also good for your brain. So lifestyle does play a role in this, and that's true whether you have Parkinson's disease or not. Um, I wish we had more specifics and more ability to fine tune this effort, but like I say, um, not everybody develops dementia over time in the general population. Um, and this issue about whether dementia is a normal part of aging, I think, can be illustrated a bit with some tables. So I've already given you a definition of dementia, and it involves impairment in mental function and cognitive function, and it involves impairment in activities of daily living, right? So that's what we have already covered. People often ask me, well, will I know if I'm demented? And what's the subjective experience of somebody in this category? And some people have very good insight into what's going on, and some people don't. So the subjective experience is a little bit variable when it comes to dementia. Now, how is that different from normal aging? Well, with normal aging, uh, the cognitive testing, whether it's done by a neurologist with a short form or by a neuropsychologist with an extensive evaluation, the cognitive testing is okay, the objective cognitive testing. The activities of daily living are preserved with normal aging. Now, the subjective experience, though, is that most people, as they get older, and as someone who's getting older myself can attest, we have trouble with recalling names. It's a very normal phenomena for people to have trouble coming up with names immediately. It's also been shown in some of the largest and longest running studies that just slowing of mental processes is part of normal aging. So there are some changes that occur cognitively with normal aging, and usually that people are aware of, but it doesn't affect the cognitive tests, and it doesn't affect the activities of daily living. So dementia and normal aging really are distinct, and I'm trying to make that very explicit in this table here. But the next question is, well, how do you get from normal aging to dementia, right? It's not like overnight people develop dementia. These are typically gradual processes. Is there a stage kind of in between normal aging and dementia? And over the last 20 years, a stage has been given a name and given a definition. And the name of that kind of transitional state is mild cognitive impairment, and it's sometimes abbreviated as MCI. And as I'll show you in a second, it's not the same as normal aging, and it's not the same as dementia. So, for example, the subjective experience, sometimes people have insight, sometimes they don't when it comes to mild cognitive impairment. When careful cognitive testing is done, though, with objective cognitive testing, people with mild cognitive impairment have a performance that is outside the range of normal. They are measurably impaired on our standardized cognitive testing. So when does it stop becoming mild cognitive impairment and start dementia? What's the difference between those two? And that is that the activities of daily living in mild cognitive impairment are intact. And we don't call something dementia until people are impaired in terms of their activities of daily living. So I hope you can see that this middle column is a kind of a middle state, a transitional state between normal aging and dementia. And that begs the question of, well, what happens to people who have mild cognitive impairment? If somebody goes to their doctor with or without Parkinson's, and they're told that they also have cognitive impairment in the range of mild cognitive impairment, what happens to them? Well, The reality is there's an increased risk of dementia in that group. More people in that group will develop dementia than people who are completely normal on cognitive testing, meaning that some of these people do progress to dementia, but some remain stable over time. And my own experience in some of our studies is that in Parkinson's disease, that's even more common than in the general population. We have a lot of people in our studies who have some modest cognitive impairment, some mild cognitive impairment, but it doesn't progress very much over time. Some people, even a little less so in Parkinson's, maybe, but in the general population, some of these people even revert to normal cognition, and I think what's happening there is that, sometimes people are tested on a bad day, or people are struggling with things like depression or, some other illness, and that's transiently affecting their cognition. And so that the outcomes for people with mild cognitive impairment is variable, is kind of what I'm getting at. A lot of the research that is underway right now in Parkinson's disease, in Alzheimer's disease, in dementia in general, is trying to identify tests that will predict which way people are going, because obviously we want to get the treatments applied to people who are at the highest risk and try to prevent them from getting worse. All right, so 3 bullets down, and now we're up to the section on what happens to people with Parkinson's disease over time. There is a myth that everyone with Parkinson's will get dementia, and that myth is not true. But I will share some challenging facts with you. So many people with Parkinson's disease do develop mild cognitive impairment or even dementia several years after the diagnosis. And different studies quote different numbers. So please take the numbers I'm going to show you here with a little bit of a grain of salt, because it varies from one study to the next. But at the time of diagnosis, uh, many people with Parkinson's disease have some mild cognitive impairment, but they don't have dementia. If they have dementia at the time of diagnosis, there's something wrong with the diagnosis. After 10 years, though, if 10 years after the diagnosis, a significant proportion have dementia, maybe a quarter of people. Some studies have higher estimates, but this was one study that I pulled recently. So that's at 10 years. And then as we go beyond 10 years, 15 to 20 years, uh, um, half or more of people who started out with Parkinson's disease have dementia. So um, these, I think, are sobering numbers for people with Parkinson's disease. But at the same time, this does not mean that all people get dementia. That we do have patients who um, are doing well 10 years after diagnosis, and the numbers you can see here speak to that. So we should be working hard to try to develop ways to prevent dementia in Parkinson's disease. But I don't think we should buy into the idea that every person with Parkinson's disease is going to get demented over time. Okay, so that's 4 myths down, and now we're on to the fifth one, and that one is dementia is only about memory loss. And I think we do emphasize memory when we're thinking about dementia, but we have to remember these are brain problems, and the brain, the cortex, covers a lot of different functions. This is kind of a famous cartoon about Homer Simpson and how different functions are localized in his brain. And it's obviously not applying to other folks very well, but it makes the point that different parts of the brain underlie different mental functions. And memory is frequently affected. This is the ability, particularly the ability to form new memories, not the ability to retrieve old memories. Language ability is a separate cognitive function, and I'm not talking about the volume of speech or the clarity of speech. I'm talking about the ability to understand words and to, create sentences. In certain dementias, that very basic human ability can be impaired because of degeneration in the brain over time. Another function that is distinct from these two is visuospatial function. And again, this is not visual acuity. This is not, the ability to read a wall chart. This is the ability for the brain to put all the information together, the ability to recognize things visually, the ability to navigate in space is part of visuospatial function. And then there's this set of functions that we call executive function. And it really should be called executive functions, plural, because there's a whole bunch of things that are included under this, including the ability to plan, the ability to sequence, the ability to inhibit inappropriate behaviors. And each of these functions is mediated by a different part of the brain. And then in addition to the thinking functions, there are other symptoms that are not cognitive per se. We sometimes refer to them as neuropsychiatric symptoms, but they are also part and parcel of many dementia syndromes. And those symptoms include hallucinations, anxiety, depression, apathy, and some others. So, this group is, and this talk is supposed to be about Parkinson's disease and the cognitive changes in Parkinson's disease. So I thought I would spend a little time contrasting the dementia that we see in some patients with Parkinson's disease with the dementia that we hear about most, which is Alzheimer's dementia. So for starters, the nature of the memory function is a little different. In Alzheimer's disease, and even in the early going, the memory impairment is pretty profound. I mean, people cannot register or retain a new item, and even with cues and everything else, they can't come up with it. When people with Parkinson's develop dementia, they have some memory problem, but it's not as severe as in Alzheimer's, at least in the early going, and they can oftentimes it's slower to come to the surface. You got to have a workaround, but it's not the profound memory problem that we see in Alzheimer's disease. As far as language function is concerned, people with Alzheimer's disease often do develop impairments in language later in the disease. Thankfully, that's not such an issue in Parkinson's. And again, I'm not talking about speech volume or speech clarity. Those things are affected in Parkinson's, but the ability to understand words, the ability to express words, those are not prominently affected in people with Parkinson's disease, even when they develop dementing syndromes. The area that they have a lot of trouble in is visuospatial function. And this is tricky because the patients, when any of us has a problem with visuospatial function, that's due to something going on in the brain, you typically don't have much insight into that. And in Parkinson's disease, there can be very significant problems with being able to recognize things, being able to organize things spatially, being able to find your way around. But it's not the kind of thing that people tend to have great insight in. And the area where this becomes really important is when we talk about driving safety, because self-regulation of driving has some role, but when people are visuospatially impaired, driving becomes an issue, and the patient doesn't have much insight into that. This other set of functions, these executive functions that I described, they tend to be frontal lobe functions. They are typically not impaired early in Alzheimer's disease, but they are impaired early in Parkinson's dementia. That when people are starting to have cognitive problems related to Parkinson's, it's often sequencing, organizing things, those kinds of tasks that they have a lot of trouble with. And then this category of neuropsychiatric features, there are features in both of these conditions, but in the early going, we don't see too much of that in Alzheimer's disease, whereas in Parkinson's, hallucinations are common, anxiety is common, and so the point that I'm making is that dementia is not only about memory loss; that there are these different functions that are affected in different dementias, and certainly Parkinson's dementia is different from um, Alzheimer's. All right, and now it looks like we're a pretty good time, and we're getting down to the last bullet, which is again a myth. The myth is that there are no treatment options because, in fact, there are treatment options. So I'm showing you a picture of a synapse down here, and whenever we're treating neurologic problems, we're thinking about boosting function in the synapses. And there are treatments options for doing this in the case of cognitive trouble and Parkinson's disease. But what I tend to find is that people with Parkinson's disease get used to taking their carbidopa levodopa, and then if they develop a problem that they think is related to Parkinson's, they assume that the answer is to take more carbidopa levodopa. And when it comes to cognitive changes or dementia, carbidopa levodopa is not the right thing because there are brain chemicals, neurotransmitters other than dopamine that have to do with this problem. So it is true that cognitive troubles can be part of Parkinson's disease, but please don't get the misimpression that that means you should take more carbidopa levodopa if you're having thinking problems, because that can actually make matters worse. So what treatment options are available? In terms of medications, I'm going to say a few words about three different categories. So there are medications that have been developed to improve cognitive function, and I'll describe them in a moment. There are also is also a long list of medications that can be used to treat hallucinations. Most of those make Parkinson's worse, so we're limited to a short list of medications that I'll get to. And then in terms of depression and anxiety, there are medications that can be helpful, and I will say a couple of words about that. So I'm going to start with the cognitive enhancers. So again, we're getting away from dopamine now, and we're looking at other brain chemicals. And there's this one brain chemical that is listed in this bullet, and it's pronounced acetylcholine. And you don't need to remember that, but the point is the drugs that are used for improving cognition are drugs that boost levels of that chemical, boost levels of acetylcholine. One of those medications goes by the generic name of donepezil. The brand name is Aricept, and I'm guessing a lot of people have heard about this medicine. It was introduced in the 90s, and it was approved for the treatment of Alzheimer's disease. And it was actually a great disappointment to a lot of people because it didn't really have a very impressive effect in Alzheimer's disease. There were just a minority of people who seemed to derive benefit from it. And a lot of doctors are very skeptical about this medicine because of that experience. What I would like to emphasize, though, is that the people for whom donepezil works are people with Parkinson's type of dementia, that people with Parkinson's dementia or Lewy body dementia tend to have a more robust effect from this medicine. And there's lots of literature, medical literature to support that contention. I've got lots of anecdotal experience to support that contention as well. But I think a lot of doctors became jaded when this medicine didn't help very much. Now, it's available as a generic pill now. It's just once a day, so that's convenient. The downside is that it can give you an upset stomach. It can cause nausea and diarrhea. People vary in their sensitivity to those gastrointestinal effects. But if you're going to have a side effect, that's the typical one from donepezil. Now, there's a second medicine in the same category that is called rivastigmine is the generic name. Exelon is the brand name. The chief role, in my opinion, right now is that uh, Exelon has the advantage of being available as a skin patch. So if you have somebody who's taken a pill that makes them sick to their stomach, it stands to reason that if you could deliver the medicine through the skin instead of through the stomach, you'd have less GI symptoms. So what I do and what some other docs do is if we're going to use a medicine like this, we usually start with donepezil. If people tolerate it, we stick with it. If they have gastrointestinal effects that are unacceptable, then we might try the skin patch as a way to try to get around that. Um, uh, Now, these medications don't typically restore memory per se, but they often help people to follow a conversation, carry out some simple activities, sequence a little bit better. Um, and then the other reality about these medications that, again, is not always widely appreciated by other doctors is it can often help with hallucinations. So it wasn't developed for that purpose, but it's something that's been observed over time that in people who have a brain chemistry that is responsive to these medicines, even hallucinations can be improved. And I've certainly seen some dramatic instances of that. So that's the first category of pills. There's another cognitive enhancer. So it's in the category of cognitive enhancers, but it works differently. It doesn't boost acetylcholine, and without getting into detail, does something a little different in the brain. The medicine is called, the generic name is memantine. The brand name is Namenda. The evidence that it really is helpful in Parkinson's disease is less compelling, but it is another option that is available to us. And it doesn't have any gastrointestinal side effects and fewer side effects in general. So sometimes we reach for this one when people can't tolerate one of the first two medicines. It's also true, though, that it can be combined with either of the other two medicines. So you can be on both. I usually try to get people on donepezil or rivastigmine preferentially. I use memantine less just because it's less convincingly effective, I think. Now, I started off with medications, but I have to say there are some treatments without medication. So there's occupational therapy. In some cases, can be helpful for giving people some workarounds. There are also some speech pathologists, not all the speech pathologists do this, but some of them have training in cognitive rehabilitation. I just pulled these pictures off the web just to give an example of cognitive training. This is, I'm not familiar with the actual group. I just was trying to give you a kind of a visual. Uh, and then, I gave you the joke picture of Homer Simpson's brain a few minutes ago, but there really are maps of brain function that are more realistic, and some of these therapists can help us to tap into those and function a little bit better. So that's in terms of cognitive function. Now, how about hallucinations? Um, Most of the drugs that have been developed for treating hallucinations, and there's a lot of them, but most of them work by blocking dopamine in a big way. And, blocking dopamine in Parkinson's disease is going to make Parkinson's worse. So when you have Parkinson's disease and hallucinations, you're a little bit between a rock and a hard place. But there are some medications in this category that can be used safely in people with Parkinson's disease. The first rule of thumb is always to, look over the medication list and try to get rid of anything you don't need that might be promoting hallucinations. So there's a variety of medicines that fall into that category, and sometimes just getting them out of the picture is enough to help people function better. But then if you do need a medication to suppress hallucinations, one option is quetiapine. Quetiapine is the generic name. Seroquel is the brand name. It's the same medicine. Um, it is quetiapine is a little bit sedating, which can be good or bad. You know, if people are needing some sedation to fall asleep at night, it might be helpful in that respect. If they need something during the day, the sedation might be limiting. The other advantage of quetiapine is that you can, dose it from 12 and a half milligrams a day up to like 200 milligrams, and even higher than that. So that, we always start at a very low dose with these medicines, and it's nice to have this very flexible dose range. I will add here that um, quetiapine has never been proven to be effective in hallucinations in Parkinson's disease per se. There have been some small clinical trials. They've been negative. At the VA, there is now a nationwide study trying to establish whether quetiapine is truly effective or not. It's being done at the VA because drug companies don't want to, prove that generic drugs work well, whereas a public entity like the VA is motivated to do that. So most of us in the field use quetiapine. Some people, doctors, uh, prefer not to because of the lack of the formal clinical trial evidence. But I think most of us use it to some extent. The second, it's also not very expensive, which is an advantage, of course. The second drug, the second choice that we have for treatment of hallucinations goes by the generic name of pimavanserin and the brand name of Nuplazid. This is a once-a-day medicine. It's just a single fixed dose. One of the advantages relative to Seroquel is that it's not sedating. One of the downsides is that it's more expensive. So it's not available as a generic drug and um, can be an issue for some folks. Um, we use a lot of pimavanserin with good success, so I think it's um, a useful drug. It's a shame that it's priced so expensively. The third option is something called clozapine or Clozaril. This is a medicine that's been around for a long time. Um, it is also sedating and has effects on blood pressure. But the most intimidating part is that uh, when this medicine is used, there is a risk of suppressing the bone marrow in a very dangerous way. And consequently, you have to do very frequent blood tests to monitor for that problem. Um, Many Parkinson's specialists swear by Clozaril for its benefits, but it is burdensome to use. So we probably use it less than the first two. Um, the third category I was just going to touch on, but it's going to be very brief, and that is that anxiety and actually it wasn't supposed to be hallucinations there. I meant anxiety and depression. That's a typo on my part. But there's a long list of antidepressants that are safe for use in Parkinson's disease. We don't have good evidence that one antidepressant is better than another. Um, we do want to avoid anything that blocks dopamine, um, but most medicines in this category don't. I'm not going to go into that in greater detail just because I was expecting we'd be running up against time constraints, and I see that we are. Okay, so the last thing I want to say about treatment is to let you know about an experimental treatment that is being evaluated right now. Um, and this approach is using one of those drugs that I described earlier, which is already FDA approved for Alzheimer's disease. Um, uh, it's relevant to Parkinson's disease because what uh, uh, the population of people that's being enrolled in this study are people that kind of have an overlap between Parkinson's and Alzheimer's disease. So it gets back to this idea that you can have more than one type of dementia at the same time. So, in the brain of people with Parkinson's disease or with Lewy body dementia, the abnormal material is something called alpha-synuclein, and the alpha-synuclein clusters into something you can see under the microscope called a Lewy body. But as I said earlier, the abnormal material in the brains of people with Alzheimer's disease is is amyloid or beta amyloid, and that's seen in the plaques. This is another example of these amyloid PET scans. On the far left is somebody who's completely normal. On the far right is somebody who's got Alzheimer's disease. In the middle is someone they don't have Parkinson's disease, but they have mild cognitive impairment. They have mild impairments, and you can see they're kind of intermediate in their amyloid level. Now, people with mild cognitive impairment vary. Some of them look more like the healthy control. Some of them look like more like Alzheimer's. Sometimes they're intermediate. Um, but the availability of these PET scans allows us to tell who's got amyloid in their brain and who doesn't. And this this drug that is now FDA approved is one of two drugs that have been tested in these clinical trials that did amyloid PET scans repeatedly in the course of the study. And if you look at this straight line up here, the measurement, the up and down measurement, is how much amyloid is in the brain. It's a measurement of how much amyloid is in the brain. So the horizontal black line here, that's the people who got placebo, and the amount of amyloid in their brain stayed the same over time. And then the lines that are going down, those are the people who got treated with the drug. And you can see the amyloid came out of the brain. And there's other data to show that they had some clinical benefits from this as well. Um, Now this study has recently started. It just was initiated in May of this year to see if that drug will work in people who have um, Parkinson's disease with mild cognitive impairment or dementia with Lewy bodies with very mild impairment. And I'm emphasizing the mild impairment part of this because we know that these drugs, as I say, they're already FDA approved. They've been through a lot of testing in Alzheimer's disease. They don't work once things are further down the road. So it's for people with very mild impairments. And what's happening is people get clinically evaluated to see if they have these mild impairments, and they have some clinical feature that suggests they've got a Parkinson's type of dementia or a Lewy body type of dementia. And then they have to have this PET scan to see if they have amyloid in their brain. So the name of the study is the Trailblazer ALS 7 study, and it's testing this FDA-approved therapy, but now not in Alzheimer's disease, but people who have dementia with Lewy body or Parkinson's disease dementia. And the study is enrolling around the country. The link at the bottom shows where to find it on a website that's called clinicaltrials.gov. The plan is to enroll 350 people. It's going to be at 72 locations. This is another set of contact information. So anywhere in the country or even beyond the country, if people are interested in this study, you can call this number or email this address. I'm not personally involved in the study, but I do think that it's an important one for us to support, and that's one of the reasons I'm sharing it with you. It will really answer an important question about the future of treatment of cognitive problems in Parkinson's disease and in Lewy body dementia. It is being conducted at my medical school, not by me, but by another doctor named Dr. Amy Pierce. I know this is a national webinar, but if anybody is in the Portland area and you wanted to get in touch with the group in our area, this is the contact information for that. And I know I'm going through these last few slides with the contact information quickly, but Anis is going to post the slides and post the presentation. So we'll make these um, uh, pieces of contact information available to everyone. All right, so now to wrap up, uh, what do we say about these myths and preconceptions? Well, first of all dementia is not the same. I hope I made that case clearly. Dementia is not the same as Alzheimer's disease. Dementia is a broader term. Alzheimer's is a particular type of dementia. Dementia is not a part of normal aging. All people with Parkinson's disease do not get dementia. Dementia is not only about memory loss. There's other symptoms in this category. And maybe most importantly, there are treatment options. So seek them out and hopefully with the currently available treatments, we can improve people's quality of life. And with these future treatments in development, maybe we'll be able to head this thing off altogether. So I will stop there, and I think Anis is going to moderate some Q&A.
Yes, we have a lot of questions, so I understand we're not going to be able to get all of them in the 9 minutes that we have left, but a lot of them are, obviously around, prevention, understanding what risks they might be at. So one had asked, if I'm diagnosed late, they were diagnosed after 80 or around age 80, and their neurologist said, you're probably not going to get it. I know it increases risk with age, but if someone is diagnosed as late onset, is that pretty much, reduce or minimize the risk of dementia at this age?
You know, I don't think I can say that with any, I wish I could tell you were in the clear, but the age effect counterbalances the lateness of the diagnosis effect. So I'm afraid I can't um, tell you not to worry about it. Well, you shouldn't worry about it anyway. You should do the things that help to keep your brain healthy, but I can't say you're in the clear.
Okay, and conversely, are there significant differences in risk or even progression of dementia in young onset people?
You know, um, there's not an overall increase in dementia with young onset, even though intuitively it would seem like there would be. Um, there are some genetic factors which modify age of onset, um, and the effects of those are surprising. So, for example, there's a gene called LRRK2. LRRK2 is associated with a little bit earlier age of onset of Parkinson's, but most of the data suggests that LRRK2 carriers have a lower rate of cognitive impairment over time. GBA is another genetic variant associated with a little bit younger age of onset, and most of the data indicates that GBA variants are associated with a higher risk of dementia. So, um, so anyway, the age of onset all by itself um, uh, is not very predictive. You have to take these other factors in.
So there was a question, is it true that people with DBS have a higher chance of getting dementia? And if so, what does this mean for them or for
Yeah,
treatments?
that's a good question. So it's not true as a blanket statement. So the studies of DBS looking at cognitive outcomes have found that many people, or they found a statistically significant effect, at least in one of the biggest studies, on uh, some verbal fluency aspects. Um, so that I think is the best evidence if we take everybody going to DBS, that that's the cognitive area that is most at risk in everybody going for DBS. Um, However, when people have significant cognitive impairment, they just don't tolerate the stress of DBS surgery and basically trauma to the brain. So it is the standard at all centers that do DBS to do a careful cognitive assessment beforehand. And if someone has significant cognitive impairment, um, they are usually recommended not to have DBS surgery because of the risks of worsening. Okay. So to restate in this, if people don't have cognitive impairment going into DBS, the likelihood that they'll have significant cognitive impairment is small. If they have significant cognitive impairment before DBS, DBS will likely make them worse, and most docs steer them away from DBS.
So what you said made me pull out one of the other questions in regards to risk, and that is if someone's had a brain injury before, and this person said it was primarily affecting their frontal lobe, but just for any brain injury in general, can this increase or lead to dementia?
Yes. So traumatic brain injury increases the risk of dementia, and there's a few different types of dementia um, that are associated with increased risk. In an individual case, it's very hard for us to pin down what the absolute cause was, but um, uh, traumatic brain injury is a risk factor for dementia. I think that's a black and white statement. Yeah.
Um, can you mention or talk just briefly about neuropsych testing? When should people have this done should they have it done for a baseline, and what can it actually tell people?
Great. Um, so, I'm a neurologist, right? So when I see patients, I do short tests, that are usually one page, and there's a few different ones. Most of them are 30-point tests, and they're standardized, and they're pretty informative in terms of getting screening for things and so on. Um, if someone if someone gets a 10 out of 30 on that test, neuropsychological testing is not that helpful to them. So neuropsychological testing is longer. It's a couple of hours long. Most patients hate it because you get pushed to your limits. But it's very, very informative. And the time that it becomes most useful to the patient and to the referring doctor is when impairments are mild and you're trying to get a sense of, is this normal aging or is this mild cognitive impairment or something else? And then, I had that table with the different cognitive functions, and the neuropsychological testing parses out each one of those functions and then can say, this is the pattern of Lewy body dementia, or this is the pattern of Alzheimer's disease, and so on.
All right, and I think we have time for one more question, and that's going to go back to questions around lifestyle and prevention. So we had a couple. One was, what do you mean by lifestyle in terms of prevention? And do activities, so I'm putting a couple of them together, and do activities such as, websites, Lumosity maybe is one I'm thinking of, or those kind of cognitive stimulation games help people with cognitive decline? And lastly, sorry to compound question here, is there anything that can be done to help with visual spatial difficulties in that prevention
Yeah,
or treatment?
yeah. Okay, so in terms of lifestyle in general, that's good for the brain. Um, uh, the rule of thumb is that everything that's good for your heart is good for your brain. And it's also true that the American Heart Association is also the American Stroke Association, and they have very good, well-vetted recommendations for heart health that also apply to the brain. And I refer a lot of my patients to their website. It's called Life's Essential 8, and it goes into these things in great detail. Now, Anissa, you at PMDA also have the Healthy Brain Initiative, which also steers people to good recommendations like that. And you can probably speak to that better than I can. But before I ask you to do that, let me comment on the particular question of cognitive stimulation, because that's something that comes up all the time. People think, well, if I want to keep my mind healthy, I should be doing mental games and so on. The evidence that things like lumosity and other um, cognitive stimulation is good for the brain is pretty good. It's very hard, however, to prescribe that in a quantitative manner the way that we can make recommendations about exercise, about diet, about blood pressure, and so on. Um, it's also true that a lot of the exercises that are out there are really boring and people don't stay with it. They try to, it's like, you buy a treadmill and it sits in your basement. The same thing with the cognitive stimulation. So what I really recommend to people is stay cognitively stimulated. Find things that you enjoy, board games, card games, Sudoku, those kinds of things. Um, but don't ignore all the other elements, including physical exercise, which has overwhelming evidence for efficacy in Parkinson's disease. Um,
Awesome.
do you want to say something about the Healthy Brain Initiative? You know more about
Yeah, so our Proactive Brain Health Alliance is it's targeted for anyone who actually wants to maintain brain health, but it also is specifically for those who are not yet diagnosed with anything yet. So they would be what we consider those who are concerned about risk. They might have a first degree relative with Parkinson's. They may have done genetic testing and have been identified as having a gene mutation. Um, they, you know, just might in general be interested in risk, and so they fall under that criteria. Or those who may have already been told they're prodromal. Prodromal meaning that they have REM sleep behavior disorder, loss of smell, constipation, depression and anxiety, and maybe some mild cognitive impairment. And so, if they're under that prodromal, but they haven't yet developed motor symptoms of Parkinson's, they would potentially want to engage in the proactive brain health. And we do education that is specific to lifestyle. We talk a lot about what that means, what some of this criteria means. There's research studies that you can get involved in if you're in that area, such as the Fox PPMI study. And so it is a place for education. We have groups where you get together every quarter and you can just ask questions of an expert about lifestyle, about things that you can do proactively to manage. And we have an entire library of programs specific to those topics. So I dropped the link in the chat. If you have not checked it out, you can go back and watch the recordings. We have quite a few.
it.
And I know we didn't get to all of the questions today. We had a ton of really, really good questions. Wish we had like another hour to delve into them, but we've already taken a lot of Dr. Quinn's time that he's so graciously given us to educate us about all these myths and misconceptions. And I really, really appreciate this because you covered quite a bit in this hour.
It was a pleasure. Thank you for inviting me.
Absolutely. And thanks to everyone who joined us. Again, this is recorded, so the recording will be up on the website. We do have the slides, those will be available as well. You can save your chat if you want to, get any of these links. I know people are sharing resources as well, so sometimes it's great to hear what others have used that has worked for them. So check those out. And we have a tradition, since we can't clap and there was over 200 of us on here, it would be really loud if we try to do that on Zoom, to do a wave of gratitude. So turn on your cameras if they're not on. Thank you, Dr. Quinn, for giving us your time. I see the emojis for those who don't, telling you how much they appreciate your time today.
Okay. Thanks everybody for coming and thank you for inviting me, Nessa. Good to see you.
Absolutely. Take care.
Bye bye.